Hello, everyone. Welcome to NIDI Grand Round. Today we have Alan Junkins presenting on intestinal parasites. Dr. Junkins.
Okay, good morning or good afternoon, everybody, whichever it is. Hang on a second, let me get this up. And I think you got it, right?
Yes.
Okay, I was thinking, we've talked a lot about bacteria and molds and other things, but we've never talked about parasites on this. So today we're going to start with kind of an intro to parasitology, with a little bit of an emphasis on the common intestinal protozoa that we see. So if you look at the way we divide up a clinical microbiology laboratory, all of these make perfectly good sense. We have bacteriology, microbacterium, mycology, and virology, and they all have a certain set group of bugs that we deal with. It's pretty simple and straightforward. But then we have parasitology. And what is actually included in this division called parasitology? Well, you would think about it, and you would say, well, what is a parasite? And this is the definition. One of the best ones I found from Google, of course. An organism that lives in or on an organism of another species and benefits by deriving nutrients at the other's expense. And I would argue that the important thing here is at the other's expense. You have the host, who is being harmed by this organism, and the parasite itself, which is getting some kind of benefit from it. So you can't really look at things like our normal flora. You see, I look at our normal flora and say, those are not parasites. That is a mutualistic relationship there. We are both benefiting from having this normal flora. We give them a warm place to live and some nutrition, and they provide us with some nutrition as well. They make all the vitamin K we need, usually, for example, but they also protect us from infecting organisms as well. So they're not really parasites. A parasite is where something damages the host, harms the host. But if you're going to use that definition, then you would have to say, well, all these infecting agents, all these pathogenic organisms that we've talked about are technically parasites. So in clinical microbiology, we get around it by just saying parasitology is everything else. If it doesn't fit into one of the other divisions, then we call it parasitology. So here are the bugs that we kind of consider in this group. We can take this overall heading of parasite and divide it up into protozoans, single cell organisms like this cyst that's up here in the top left, and then metazoans. Metazoans will be your multicellular organisms, the bugs that we would really think of as being full-blown animals. Those would be metazoans. And the protozoans we can divide up into different classes. This is based upon their motility and also on their mechanism of reproduction. We divide them up into those four groups. The metazoans are divided up basically into helminths, which are the worms, and then arthropods, the ectoparasites that live on the outside of a human body. So ticks, lice, bed bugs, mites, those kind of bugs. And if we want to divide up further, you can divide the worms up into roundworms and flatworms, and the flatworms are divided up into tapeworms and flukes. So that's pretty much all the bugs. None of these bugs really have anything much to do with each other. They're not in the same families. They're not closely related to each other at all, of course. But it's a way for us to categorize them when they come into the clinical microlab. So let's look at some of the, we're not going to go through all of these. Don't look at the list and think this is what we're covering today. But I want to kind of give you a list of the more common parasites that we would deal with and what we use to look for these specimens. So you can see a lot of these are stool specimens. Most of what we do in parasitology is really going to be stool. And all of these bugs here, both protozoans and helminths, are bugs that we can look for in stool specimens. But there's blood parasites as well. We will look for those. And then you can't forget these other guys as well. There's a smattering of other things, including the #1 parasite in the entire world, Trichomonas vaginalis, in genital specimens, Acanthamoeba and Naegleria in spinal fluid or brain tissue. Enterobes vermicularius, really in Scotch tape reps, not really in stool. Urine for schistosoma and respiratory specimens for Paragonymous and also for Pneumocystis. These ones that are tissue parasites over here, they really tend to be in tissue. So those are things that we don't really do very often in microbiology. Those are things that are really going to be diagnosed either serologically or in pathology. Obviously, we're not going to go through all of these. We're going to concentrate today on stool protozoans to kind of go through the process of what we actually do with the stool and what we're looking for. So first of all, this is something that a physician is going to have to suspect. They're going to have to order a test specifically for parasites. So you have to kind of think about, when do I look at a gastroenteritis and think that this might be a parasitic gastroenteritis? And here are some clues, and they are just clues. There's really nothing that really stands out here as a dead giveaway. But typical symptoms: diarrhea, bloating, blood and stool, weight loss, symptoms often lasting 2 weeks or more. What that really tells you is that a salmonella or a shigella or a campylobacter, they're not going to last that long. If you've still got symptoms after 2 weeks, then you may be, okay, we can forget about those and start looking more at parasitic infections. Compatible epidemiology, travel to endemic area, poor hygiene, child care settings or other institutional care settings, a weakened immune system. All of those look great until you kind of realize that when you get right down to it, all of those are also risk factors for other forms of gastroenteritis as well. And then if you think this really is an infectious gastroenteritis, but the other tests have all come back negative, then we can start looking for parasites. So those are kind of things that you may be looking for. Now, I know you all really wonder what we do with this poop once we get in the laboratory. So let me spend a couple slides here going over what we actually do to do the classic parasitology test, which is going to be a stool, ova, and parasites exam. This is really what we want to get. We set up these little 2-vial packs that we want people to use. A white top vial here, which is a clean vial. What that means is this is just an empty tube. This is no different from sending a cup full of poop. There's nothing in here. Okay. This yellow top one has a formalin-based fixative in it. That is going to preserve the structure of some of the more delicate forms, the trophozoite forms of some of these protozoa. So that's what we want, one of each of those. Some laboratories will also have this PVA, polyvinyl alcohol based fixative. We really don't use that in our laboratory. We will do it if somebody sends one to us. It's not a problem, but we don't include that in the specimen collection packs that we send out. Big rule with parasitology is we really want 3 specimens over, this says a 3 to 6 day period, but you could say more like a 3 to 10 day period before you really decide that that patient does not have parasites. The reason is the O&P exam for some bugs in particular is not particularly sensitive. And there are issues with intermittent shedding of some parasites. So you may not have much right now, and you may have a lot more tomorrow. So we really want 3 different specimens spread out over some time. I'll be honest with you, we hardly ever get this. Most of the time when somebody orders an O&P exam, we get 1 specimen and that's it. Not really the best way to do it. You do want to avoid some things that are going to really mess up our system of looking at these or possibly cause some contamination. And we do have a 3-day rule. It's a good idea to have a 3-day rule for parasitology exams. The 3-day rule we definitely have in place for stool cultures. If the patient has been in the hospital for more than 3 days, then we're not going to do a stool culture, or we're not going to do an O&P exam. And the reason for that is that you don't acquire these in the hospital. These are not things that come on while you're in the hospital. The yield is extremely low in those situations. So basically, if obviously if the patient has symptoms at the time they're admitted, and I've seen this happen before, where a patient has gastroenteritis the day they're admitted, but they don't actually order any stool cultures or stool specimens for 5 days later, then that's a different story. So if you're going to be more than 3 days beyond admission in the hospital, talk to the microlab, and well, we can certainly accept those. Once we get it, this is basically what we do. The clean vial, we're going to put a little bit of poop on a slide and put a drop of saline down, use a saline wet prep, and we will take a look at that microscopically. And then another one with some iodine in it, which is going to stain the interior structures of some of these protozoa. But we also go through a concentration method. We take this stool in this formalin fixative. This is the best diagram I can show you. I've just Googling around for this. This is not exactly how we do it, but yes, a piece of gauze that you kind of pour it through. So all the big chunks. Okay, I know, I'm sorry. You got to talk about poop here. The big chunks get filtered out, and you take the less, the stuff that passes through the gauze. And we'll do a concentration method. This is with ethyl acetate. You mix that in, that's going to kind of extract all this fatty debris. We'll take that, we'll spin it down, the ethyl acetate will sit on top. There'll be this layer here of debris. And then down at the bottom is where you're going to get all the goodies. All the parasites, other things are going to be down here in this little pellet down at the bottom. And we'll do more, another saline wet prep, another iodine wet prep. And then we'll do a trichrome stain smear, which will really do a good job of staining the interior structures and also allow us to observe that on the oil immersion objective. So we can get 10 times better magnification with that. And then you'll have some poor soul like Brent here who will have to sit there all day long and look under the scope, scanning these slides to look for various organisms. And just to kind of show you what can make this difficult is if you look at the size range that you're looking at, these are the protozoans over here. The smallest one is really going to be Cryptosporidium, which is going to be somewhere around 4 to 6 microns across. And then they range up to Neoballentidium, which is going to be somewhere up around 80 microns across. The helminth eggs, we don't really ever see the adult worms, except in rare situations, but the helminth eggs, Clonorchus is probably the smallest one at about 27 microns across. There are some smaller ones, but they're very rare. And the big dude is going to be a schistosoma egg at 200, about 180 microns across. And it's kind of funny sometimes because sometimes you'll spend so much time looking for things down in this size range, you'll just go right over the top of these and not even notice them because you're not looking for something that large. So it can be kind of a difficult thing to do. It's made more difficult from the fact that we don't have a whole lot of parasites in this part of the world. So the great majority are going to be negative, but you still need to spend a good bit of time scanning those to look. The sensitivity, we've talked a little bit about the exam, and it's kind of hard to put a number on because it's going to be heavily dependent upon the organism. It's going to be very low sensitivity to Cryptosporidium, but a much better sensitivity to detect some of your helminth eggs over here. And also the skill of the microscopists. People who know what they're doing and have experience doing it are going to be better at it. But I did find this one line from one of the Bibles that we use of lab manuals for parasitology. Data suggests that 40 to 50% of organisms present will be found with only a single stool exam. So you kind of turn that around, and what that's kind of saying is a single stool exam is going to be about 40 to 50% sensitive. That's kind of why we really want you to send us 3. So that's the microscopic OMP stool exam. There's a couple other ways we can do this. There are antigen tests available, and in the United States, that's almost always going to be a combination of Cryptosporidium and Giardia antigen. These are long regarded as the 2 most common protozoal parasites in the United States, Crypto and Giardia. So we can run this test here, which will look for antigen in the stool specimen. You put your specimen in here and you'll see the little lines show up here for Crypto, little lines showing up for Giardia, and then your control dots there in the center. In the United States, as long as you have somebody who really has not traveled outside of the United States, this is really recommended as the first test. Do this first. You'll have higher sensitivity to detect Crypto or Giardia than you would have on a microscopic exam. So do this first. If this comes back negative and you really think that this patient has a parasitic infection, then we can follow that up with an O&P exam. That's something else that we do recommend here, but not many of our physicians follow. We really get more O&P exams than we get Crypto Giardia antigens. Since it's more sensitive, you really only need one. You don't need those 3 specimens before you can call them negative. And obviously, it's faster, it's cheaper, it's much easier to do, and you don't need a real skilled person sitting there looking through the microscope. So this is really considered to be the best test to start with. And these days, you can't overlook the GI pathogen panels. The one that's really on the market, great highest share of the market is going to be the BioFire GPP, the gastrointestinal pathogen panel. These are the 4 parasites that it looks for. There are others out there. The only one that I know is really on the market now is the BD Max from Becton Dickinson, which looks at Crypto, Entamoeba, and Giardia. So the advantage of these, it covers a lot of bacteria, it covers a lot of viruses, it covers those 4 parasites. And because of that, you don't need to specifically be thinking about parasitology. You can just say, this person's got gastroenteritis, I'm going to run the panel. I don't need to kind of think in my mind, is it possible this is a parasitic infection? Theoretically, and some labs have trumpeted this idea, is that if you do this test, then you don't need to do O&P, and you don't need to do stool culture, and you don't need to do a norovirus PCR, and you don't need to do the rotavirus antigen. So you could do this one test instead of 4 or 5 other tests, and that would actually save money in the long run. I don't see that. This costs more expensive than all of those tests put together, so I don't quite see that. Disadvantages, it's expensive for the lab to purchase it, it's expensive for the patient to pay for. And I would also point out with these interpretive difficulties. Some of these are very rare bugs, have a very low pretest probability. And as a result, you really have to question the positive results. I'll give you this as an example. Crypto Giardia, very common in the United States. Okay, Entamoeba histolytica, not very common. This is data from the Midwest region for the last 3 months. And you can see only 0.1% of these gastrointestinal pathogen panels that have been done across the Midwest have been positive for Entamoeba histolytica. The test has a false positive rate. If you look at their package insert, somewhere between 0 and 0.2%. That's the false positive rate. So somewhere around 0.1% of the tests are going to be false positive for Entamoeba histolytica, which kind of tells me this may actually be 0 histolytica whatsoever. But what it tells me is that if you get a positive hit for Entamoeba histolytica, especially in a patient who has no risk factors for Entamoeba histolytica, it's probably a false positive. So you do have to worry about that when you're doing these big panels, and people do not necessarily have risk factors for every single one of those bugs. I do want to point this out. We're going to go through a few parasites here for the rest of this time here. But I wanted to point this out. This website, I think this is one of the best things the CDC has ever done here. If you want to know parasites, look at this DPDX website at the CDC. If you go to this index up here, you can read all about every parasite that's out there. It's good information. It gives you the life cycle, gives you the symptoms, it gives you pictures, it gives you diagnostic information about the level you want to have. It's not textbooks. It's not 50 pages on Giardia. It's like 2 pages on Giardia. So that's a great website to use as a reference for any parasitic infections. But let's talk about the biggies with protozoa in the stool. Entamoeba histolytica is a biggie just because of its history, because of the disease that it causes, the cause of amoebic dysentery. Ingestion of water or food contaminated with human feces. This is not an animal bug. This bug colonizes humans. So you have to be exposed to human feces, which doesn't happen really all that often. And as a result, you don't see a whole lot of it in the United States. Unless there's some breach of hygiene, you're not going to see it a whole lot in the United States. Don't want to get into too much detail here about pathogenesis, but I just want to show you this is what he does. You eat the cyst, it comes in, it develops into the trophozoite, the actively feeding form, colonizes in the mucus layer. That is an asymptomatic state right there. And I want to point out about these parasites, histolytica, and I'll also mention again with Giardia, most infections are asymptomatic. So if you go back to that PCR panel, most of those people who were positive were actually asymptomatic in terms of histolytica. That wasn't the bug that was causing their symptoms. It's very, very common for these parasites to be colonizing a human without really causing any symptoms. But he gets out of control. He will come in here, he will degrade the whole epithelial lining. And then one thing that is unique to histolytica is that he can get into the bloodstream and go form abscesses somewhere in the body. He loves the liver, very common cause of liver abscesses, but can also cause these abscesses in other organs as well. So your general symptoms, diarrhea, stomach pain, stomach cramping, but the upper end, the more severe end is when it develops into dysentery, which is going to include bloody stools and fever. I also want to point out that there are lots of other species of entamoeba. You will see in your lab reports, we'll talk about entamoeba hartmanni or entamoeba coli. Those are non-pathogenic. They are not causing the patient's symptoms. But it does indicate if you've got that, then you have a patient who has been exposed to fecally contaminated food or water. They're transmitted the same way. So if I see a bunch of entamoeba coli, then I'm like, okay, the risk factors are there to develop a parasitic infection. But entamoeba coli is not the one causing the infection. This is what histolytica is going to look like under the scope. If we do an iodine wet prep, this is the cyst form right here. You can see 10 to 15 microns in diameter. And then the trophozoite form, the actively feeding, the pathogenic form. The cyst form is what you're going to get. That's the infective form. That's what you eat or drink. The trophozoite is the one that's actually going to do the damage to the tissue. That's what he's going to look like right there. I do want to point out also that there is another species called entamoeba dispar, which does not cause symptoms whatsoever. Looks exactly like. I cannot look at these pictures and tell whether that's histolytica or dispar. And so when you see a lab result, it may say entamoeba histolytica / dispar. And we don't know which one it is. We don't know. Let's talk Giardia a bit. Giardia is, again, water or food. This is human or animal feces. In this case, the same strains of Giardia that infect humans also can infect animals. So you can be exposed to animal feces. Classically, we talk about, backpackers drinking clear mountain streams that are full of bear poop. That's the kind of thing that you'll get Giardia from. This is just a cool picture here. This is a little Giardia trophy here, just latching on. They have this sucking disc, and they will latch onto the epithelial cells, and they just kind of suck nutrients from those cells. That's going to damage the cells, kill the cells, and cause this inflammation there on the epithelial lining. So symptoms here with Giardia: abdominal pain, diarrhea, malabsorption. So you get this very fatty, stinky diarrhea that comes from there. But you do not get dysentery. There's not going to be the blood or the fever that you get with histolytica. And there are a lot of people who have chronic infections where the only thing is recurrent diarrhea, which means you may have diarrhea for a few days, and then you go a month and then you have diarrhea for a few more days. And then weight loss, because it's absorbing those fats. It's interfering with the absorption of the fats. You can just not be able to keep the weight on. Again, most people who are infected with Giardia are going to be asymptomatic. This is what he looks like. Everybody loves Giardia because Giardia has these two nuclei right up here at the top. This is the cyst, this is the troph, and so they look like eyeballs. And he's always looks like a face. You know, Giardia is a friendly little, microscopically at least, when you look at it, kind of a friendly little look. He's got this thing here called the axoneme, which looks like a long nose, and sometimes little smiles as well. So everyone likes Giardia. Crypto is probably really number one as far as intestinal pathogens in the United States, intestinal parasites in the United States. Water or food contaminated with human feces for the most part. There are some occasional animal transmissions, mostly from cattle to humans. Cryptosporidium parvum, the number one cause of cryptosporidium in the United States, also causes disease in cattle. So we can get it from there. But really big in recreational municipal water sources. So contaminated pools, contaminated water slides. And in some cases, there's been city water supplies that have gotten contaminated with cryptosporidium. Can lead to huge outbreaks of disease. This is not a cryptosporidium specific diagram. This is a coccidian specific diagram. So these pictures here don't look exactly like a cryptosporidium, but it's the same kind of thing. You eat this oocyst, it infects the epithelial cells in the intestine, and eventually it's going to multiply to form these merozoites. It's going to kill that epithelial cells, break out of those epithelial cells, and then go back and do the whole thing all over again. So it really is acting kind of like a virus, really destroying these epithelial cells one by one. At some point along the process, it's going to go into more sexual reproduction, where we'll make the male and the female, they'll fertilize right there in your gut and form these oocysts, which is what we're going to be looking for when we do the microscopic exam. Symptoms kind of similar, low-grade fever, cramps, 5 to 10 frothy bowel movements every day, and it takes a while, 2 to 3 weeks in an immunocompetent person. Immunocompromised people really can have a very severe infection with cryptosporidium, life-threatening malabsorption and wasting. As far as asymptomatic, you don't find much about how many asymptomatic infections there are. There are some, but we don't have a good idea on what percentage are asymptomatic. This is what he looks like. This is a saline wet prep, 4 to 6 microns, tiny little guy. There's no really definable internal structure. Very, very difficult. I can tell you, you can look in any poop specimen and you'll find something that'll look a lot like that. So very, very difficult to identify in a saline wet prep. Luckily, we have some helps with him. Very strongly acid-fast positive, nice, beautiful red stain if you do an acid-fast stain. And there are immunofluorescent stains available, this one with cryptosporidium and also Giardia at the same time. So there are some additional ways to do that, not to mention do the antigen test, much easier to do than an O&P exam. And I want to finish up with one more. I want to talk about Blastocystis hominis, which actually is not a protozoan. It is now classified as a straminophile. If you're like me, I had no idea what a straminophile is, but you know, algae, diatoms, watermelon, it's basically a kind of algae that behaves very much like protozoan parasites do. So we kind of treat it as though it is a protozoan parasite. Not much is really known here. We know it's primarily human to human. We just presume that it's going to be fecal oral. Common colonizer, almost all the time going to be asymptomatic. Now, that is also true for Histolytica and Giardia. It has been associated with GI symptoms, though. And I put this diagram in here just to show you that somebody has done some research to show that it does have various virulence factors that can cause illness, can cause symptoms, including here host cell apoptosis, just killing these epithelial cells. So there is reason to believe that it is pathogenic. But there's a big debate about it. Some people say it does not cause disease at all. It's just a non-pathogenic protozoan type organism that you will commonly find in people's gut. Other people say that it does cause disease, particularly in immunocompromised patients. So if we really don't know about it, why am I wasting your time talking about this one? I mean, here it is, it's 12:30 and I'm still going on. Well, I bring this one up because it is the #1 most common bug that we do report in our O&P results. We see more blastocystis than we see Giardia or crypto or any of the others. It's our #1 and has been forever. We have had a couple large outbreaks in the Louisville area in the last 10 years. I say it's an outbreak because we got a lot of positive results. I can't say whether they were related to each other or what, but there have been a couple big spikes in the number of cases of blastocystis. And this is also the only bug that I have ever gotten a thank-you note for. This is a patient who had diarrhea for like a year. Been to lots of docs, they couldn't figure out what was wrong. She came to us, we did an O&P, reported blastocystis. She got treated for blastocystis, and she got better. And this is the only time the laboratory here has ever gotten a thank you note from a patient for finally letting her have her life back. So I have a little bit of a soft spot for it. Now, the truth is that doesn't really prove anything. I mean, she may have been nuts, it may be completely psychosomatic, but whatever. I can't blow off blastocystis because of that. This is what it looks like. This is a huge blown up picture. It's really quite small. A big size range, 6 to 40 microns, but it really tends more down to 6 to 10 size for the most part. Big kind of empty space in the middle, and then these little dots of chromatin on the outside. Here's a trichrome stain, beautiful central body, and then these stained chromatin on the outside of it. So that's our #1 bug that we get. So here's the list again. Here's the ones that we've talked about. Obviously, there's a whole lot more parasites that we can talk about. And perhaps one of these days we will hit some of those as well. And I can show you some really cool pictures of some of those. So that is it for today, though. You'll just have to wait till some other time for those other parasites. Okay, that's all I've got. If anybody has anything they want to ask or comment on, feel free.
All right, well, thank you so much, Dr. Junkins.
Okay.
So next week, we will not have the grand rounds on the 22nd, but we will be back on November 29th with Dr. Clover talking about treatment of intestinal parasites. Well, thank you, and I will see everybody on the 29th.